Okay, my name is Michael Purdy. I'm a nationally registered paramedic, North and South Carolina paramedic state cards as well. I'll be leading you through Chapter 9. This is our patient assessment chapter. Of course, remember, this is just an overview of the chapter, so after you watch this lecture, please go back through your actual material and review the chapter more in depth because there is a lot more information in that chapter as well. And of course, at the end of this, there is a review quiz for the chapter that needs to be taken as well. So, introduction to this chapter. As EMRs, many times you may or will be the first people or first responders to initially arrive on scene of an incident. You never know where that incident's going to occur. It could be just around the corner, or it may be several miles away, or several districts away. Depending on what type of incident you're responding and what type of agency you're involved with. First and foremost, when we arrive on scene, we will conduct what's called a windshield survey or a scene size up, as you can see here on your screen, and we want to perform our primary assessment. So during our scene size up, we're kind of assessing what's actually going on, what we're looking at. If it's, for example, a motor vehicle accident, how many vehicles are involved. What's wrong with the vehicles? Is there a vehicle on fire? Are there chemical spills? How many patients do we have? Things like that. And then, of course, we want to kind of include in that same scene size up our patient or our primary assessment of what kind of resources we're going to need and what the process of mitigating or dealing with this incident is going to involve. Then we need to obtain our patient's medical history, primarily their present medical history, what has happened leading up to this point, causing our interaction with them, and then perform our secondary assessment, and then after all that's complete, our reassessment. And of course, we're always going to treat and render, our treatment is going to be rendered based on the skills that we've been trained up to. That's our scope of practice. And it's going to be based on what the patient's symptoms are being presented to us and what we are finding through our assessment. Okay, so our scene size up. Utmost paramount is safety or scene safety. We want to determine our mechanism of injury is how did this patient actually become injured or ill. And remember, when we kind of tend to lean towards the accidents or the traumatic injuries when we're talking about scene size up and mechanism of injury, but keeping in mind a lot of the majority of our calls that we respond to are medical related. So we will be coming into people's living rooms or their bedrooms, and we'll be trying to determine what the nature of illness is as well, what caused them to get sick. A lot of times, for example, food poisoning from the night before, and then they wake up at 2 or 3 o'clock in the morning feeling very ill. And of course, always we want to take our standard precautions. You will come to know this intimately as PPE. This is usually our body substance isolation with our gloves, if necessary, surgical masks or respirators, depending on what type of call. Hopefully, in our dispatch comments, we will be given information to indicate whether or not it might be some type of infectious disease or something like that. But it is always a good idea to keep your surgical masks or your N95 respirators close at hand so that if you do accidentally walk into an incident or a residence or something like that where you realize, oh, this might actually be an infectious disease, something like the COVID or the flu or something like that, you can quickly put that on. And then, of course, every time we have patient contact, we should be wearing our nitrile gloves. We tend to stay away from latex. With the latex allergies, we never know who actually has an allergy to latex, so most agencies use the nitrile gloves nowadays. And of course, how many patients are we dealing with? There's been many occasions on medical calls I walk into a bedroom and we have an elderly couple who are both presenting with the same signs and symptoms, and they both require treatment and transport. So we always need to find out, is it just 1, 2, 3, or an entire family, household, or an entire busload of children or a tour bus, something like that. And then, of course, considering our additional resources, how many ambulances are going to be needed? Will we need additional lift assist for the fire department? There's some sort of extrication need. Sometimes it's as simple as just getting down an extremely narrow hallway, and so we're going to require more manpower than just 2 to 4 people. So for our assessments, we use the information and a simple patient assessment findings to identify and manage immediate life threats. And when we say immediate life threats, we're talking about the patient can't breathe or is not breathing. So for an actual airway obstruction, or they've already quit breathing or stopped barely breathing. And then, of course, massive hemorrhage or another immediate life threat. I like to use the example of a car that is stuck on a railroad track with a train that we know is coming and will not stop. That might be like an immediate extrication type of thing, or the vehicle is on fire. We need to get them out of that vehicle immediately. Address those situations, manage them with the training and the scope that you have. Of course, we're not going to be doing pleural decompressions on a patient as an EMR. We're not going to be doing a emergency tracheotomy on a patient as an EMR. We have to make sure that we do our interventions within our training level. So for our primary assessment, we want to identify those immediate life threats, manage those, mitigate them, and then perform a general impression. This is where we're looking at what is going on with the patient, what is their problem, so to say. Assess their level of responsiveness, and that's as easy as just walking into a room and introducing yourself. Hi, my name is Michael. I'm a paramedic with EMS. How are you and what's your name? Or however you want to introduce yourself, but establish some kind of connection. Most people will at least look at you minimally. At minimum, they will look at you. They will acknowledge your presence in the room. And then, of course, our rapid exam to identify our airway, breathing, and circulation, where we talked about massive hemorrhage, airway problems, or obstruction. And then, of course, as an EMR, you're going to be updating your responding EMS units or ambulances if you are the first on scene. So when we're doing our assessment, we want to take a very systematic approach. That really kind of depends on the individual. I've come up with my assessment system that I pretty much do with every single patient that I come in contact with. I have a process. I do the same thing with my pre-hospital radio reports that we'll get to here in just a little while. And once I kind of become accustomed to that process, it makes it much less likely for me to miss information or miss an assessment. So we want to come up with that system for our individual selves, and you can do that while we're doing our practical lab sessions with fellow students or your instructors who are doing our mock assessments on. Then, of course, we always want to get a good set of vitals. We want to get an accurate set of vitals. So practicing taking a set of vitals is very important. We don't want to be guessing. I think the heart rate is this. I think the blood pressure is this. Obviously, sometimes that's unavoidable. Sometimes you just cannot get a blood pressure. You can't really feel a pulse, or you can't get an accurate pulse. But we have other ways to assess for circulation and breathing and things like that. And then, of course, after our secondary assessment, we've kind of gone from head to toe. We've looked at our patient and kind of figured out what's going on and addressed the immediate life threats, and then done our secondary treatments. Now we're going to come back and do a third assessment, or our reassessment. And this is where we're really making sure that we haven't missed anything substantial, or we're also coming back to our tertiary injuries or tertiary complaints, and we're addressing those at this point. So this might be something like a minor abrasion on the shin or elbow or something like that that's not really bleeding, but it still needs some kind of bandage on it. During this reassessment, we're going to repeat our primary assessment, reassess our vitals, reassess the chief complaint, kind of affirm with the patient if that's actually what's going on. Sometimes in heightened states of anxiety, people kind of perceive pain and different complaints differently. They don't really remember the event that just happened as accurately as they might in a few minutes. So they might remember some additional details about that incident, especially for traumatic injuries or accidents, things like that. And then, of course, what we want to recheck our treatments our treatment's effectiveness. Did we actually bandage or splint that limb properly? Is the breathing treatment helping the patient? Are we effectively ventilating the patient? That tourniquet that we put on that garden hose hemorrhage, is it actually stopping the hemorrhage? Or has something changed to where now, even though you did it properly and effectively initially, now something has changed. Maybe we've moved the patient and it has caused a change in your bandaging or your treatment to not work as effectively anymore, and we need to address that. History taking can be more simplified and made more effective by using what we call the sample history. This provides you an algorithm and a step-by-step method of taking a patient's history. So we start with the S, which stands for signs and symptoms. Signs is things that we can see. Symptoms are a result of the condition. So tachycardia or an increased heart rate, lowered blood pressure, altered mental status is one of the biggest first indicators or symptoms that is something is going on. And then the next letter would be A for sample. That represents allergies. What are they allergic to? Or are they allergic to anything if they are? And then we have M for medications. Do they take any kind of medications? Are they prescribed medications? And also, very importantly, have they taken medications that they weren't prescribed or things that they possibly shouldn't have taken? And then pertinent medical history. This is more what has led up to why did you call 911? Why am I standing here in your living room? What has brought you to the point that we are at now? And of course, we want to know L, which is their last oral intake or their meal. What kind of contents are in their stomach? This is more relevant for the hospital, but it can also be a good indicator for us. Did they ingest some kind of poison or some kind of toxicity, something like that? And then also the events leading up to the incident. This can be very, very easily phrased as, what were you doing right before you started feeling sick? And if they say I was driving my car, texting my friend, well, that's probably why they wrecked their car. So we always want to kind of review our dispatch information. If you're responding to a call with a partner, that's on the way to the call. It's a really good time to kind of back and forth with each other and kind of develop a plan with each other, how you're going to approach the incident. We want to figure out what the main or the most crucial problem is, or the type of incident. Is this just simply a medical call, traumatic call, mass casualty, things like that? How many patients do we have? Are there any safety issues at the scene? Honestly, ideally, this should kind of be more forefront when we're reviewing our dispatch information. For example, is there information in our dispatch that would indicate that we should probably stage off scene for fire department to take care of something, or even law enforcement to take care of something? A lot of domestic disputes and things of that nature, we should, especially on the medical side, we should stage off scene until we're cleared to come in, because we are not trained or equipped to deal with those situations as a blanket. Other factors, what time of day is it? What's the traffic going to be? Is it rush hour? Is it a holiday weekend? What day of the week is it? Is it a work day, weekend, things like that? And then, of course, weather conditions. Is it snowing? Are the roads icy? Fog? Environmental factors with extreme heat or extreme cold for the patient when we're talking about hyper or hypothermia, things of that nature. And then, of course, we always kind of want to be table-topping other scenarios and preparing ourselves for how would we manage that when we arrive on scene, and what are the steps that we would take to get additional resources rolling, or how would I interact with my partner or other team members, and what jobs and roles would we take when we arrive. And then, of course, if you're driving along and you have a radio and you come up on a medical emergency or a traumatic emergency, you can use your radio to contact dispatch, but nowadays using our cell phones is pretty commonplace as well. So there's just a review. Remember what time of day, what day of the week, what is the weather like. Here recently, at the time of this recording, yesterday, we had a fair amount of snow. I think Tennessee was getting anywhere between 1 to 6 inches in an area that we were driving. So the roads went from very, very good for us, and within 20 minutes, we actually had some slippery conditions. So taking things like that into consideration. Always ensure scene safety. These guys in this picture here, I don't know who they are. It's just some random picture I found on the internet, but I think the sign, their hats is SFD, which stands for some fire department. We always want to park our vehicle so that it helps secure our safety. So if we come up on a traffic incident, we're going to park towards the oncoming traffic, park our vehicle at an angle where it would deflect any other vehicle that might impact it away from the scene. We want to park far enough away from the incident so that our vehicle does not become propelled into us if it is hit. We want to scan the scene and determine the extent of the incident and damage. Are there more than one vehicle involved? How many patients, of course? What kind of hazards? Are there any chemical spills? Is there gas leaking? We want to determine if that is steam or if that is smoke coming out of the car. Is that radiator fluid steaming off, or is that something that's actually smoking? So visible hazards that we can see, is it a crash or is it a crime scene? Fallen electrical wires, remember, I kind of harp on this a lot, or you will notice that I harp on it a lot. Every line is live until proven otherwise by the power company. So don't let somebody come on scene and say, I'm an electrical engineer, that line's not hot. That's a guy line. I know that doesn't have power. It can be arced, it can be crossed, it can become energized. Power can travel down things that are not necessarily conductive in a general sense. So we could have power traveling through the ground and down actual power poles or on guy lines. Traffic, what's the traffic like? How fast are they coming? How heavy is the traffic? I already mentioned gasoline. Is the vehicle or the building or the surface that we're standing on unstable? And how do we do that, determine that? We walk up and grab the vehicle and we shake it or shake the wall? No. We use our judgment and we look at it and we determine whether or not it looks or feels safe or stable. If there's any doubt, consider it unstable. And then, of course, our weather. And then crowds are a big factor. You can turn an incident where you're dealing with one patient very chaotic and very hectic in the middle of a crowd, especially at a concert where there's loud music, lots of shouting, people really not paying attention. You can make an incident extremely chaotic just by adding those large volumes of people. So remember, electricity, you can't see it. Usually by the time you feel it, it's extreme pain and it's too late. Biological hazards, that's just kind of floating around in the air, whether it's gaseous or particulate based. We have hazardous materials that we may not necessarily see initially. When they become mixed, they can cause poisonous fumes. If the scene is unsafe, we want to keep people away. We want to exclude the scene until a trained team arrives, whether that be hazmat, some type of specialty rescue, or law enforcement. So for determining our mechanism of injury or our nature of illness, we're going to look for clues that may indicate how the accident happened. Ask the patient. That's one thing we should always or never forget, is ask the patient. Even if they're feeling ill or sick and they're sitting in the chair and we're all standing above them, around them, somebody should be at least on eye level with the patient. But always ask that patient. Give them ample time to answer you. I've seen many times where somebody will ask a patient a question, they don't immediately get a response, so they stand up, turn their back to them, and start talking to a family member or a friend, and they forget that the patient even exists. It's just disrespectful, and it's a good way to make your patient upset or agitated. But you can utilize family members, bystanders, in particular in the case of unconscious patients, where they cannot answer you or something is preventing them from answering you. And then never rule out any injury without conducting a secondary assessment. So our primary assessment is kind of our 60-second assessment. That's what's going to kill them in 60 seconds or less. We're going to go from head to toe rapidly, and we look for that massive hemorrhage, airway problems, any holes in their chest, abdomen, punctures, impalements, things like that. And then when we do our second assessment, we go back through that and we look at it in more detail. And we make sure that, oh, is that actually going to, or may that potentially be a life threat? And I overlooked it when I did my 60-second primary. We always want to take our Scene Safe BSI, our gloves and mask, discuss or consider if there's any additional PPE required. Do we need SCBAs? Do we need Tyvek suits? Things like that. And then, of course, after every single patient contact, we need to wash our hands thoroughly. And then, of course, if anything's contaminated, go ahead and wash those and change into clean clothes, things like that. If you have additional patients or multiple patients, you can automatically assume if it's just you responding, whether it be POV or a QRV, something like that, you can just assume if you've got more than one patient, you're automatically overwhelmed. So even if it's 2 patients, you probably need someone else to come and help you. You may be able to get by on some minor incidents. If it's you and your partner and you roll up on 5 patients, that is technically a mass casualty incident because 2 people cannot take care of 5 patients. So you should initiate the process of triage, which we will cover later in this course, and start triaging your patients and request additional manpower, additional resources, ambulances, fire apparatus, law enforcement, whatever you feel that you need. Maybe it's all of it. The utility company and car tow trucks or wrecker operators are good resources to have. Again, we never want to touch a vehicle that has a power line on it unless we can confirm that that line has been de-energized, and that's where the utility or power company is going to come in. Sometimes, if you don't have enough training or enough familiarity with it, we can't tell the difference between a cable line, a phone line, a power line. But also remember, if a line that would normally not have hazardous electricity running through it is hanging, it could become crossed with something else that does. So what is the purpose of a primary assessment? Well, we want to identify our life threats to our patients. We want to find out, is something trying to kill them right now? And do we need to address this right now? So we want to form a general impression of the patient, kind of approximate, or if they're conscious, you can ask them, how old are they? If you have to ask them, you can ask them, are they male or female? Sometimes it is difficult to determine that, but medically we do need to know whether they were born a male or a female. Determine whether the patient has experienced trauma or illness or even both. And then determine their level of consciousness. And we can do that simply by, again, coming into the room or coming up to a car and introducing ourselves and saying, hi, my name is Michael, I'm a paramedic, what's your name? Oh, they're unconscious, cool. We have determined their level of consciousness, or they will respond to you. Assessing our level of responsiveness, if they are unconscious, AVPU is a good scale. You'll see in the bottom of your screen here. It is a good scale to determine the level of unresponsiveness if they don't respond to you verbally. So we have A stands for alert. That's where I walk up to you and introduce myself and you respond to me. V is verbal. So you walk up, they may not look at you, but they will answer your call or answer your prompts. And then pain, you may have to actually kind of pinch their skin a little bit, rub their sternum, kind of agitate them a little bit to elicit a response. And then, of course, they don't respond for unresponsive. So to perform our rapid exam during our primary assessment, this is something that I like to keep contained within a 60-second window. You know, I'm going to start from head, I'm going to work my way to the toes, looking for anything that's going to kill the patient in 60 seconds or less. Again, airway obstruction, massive hemorrhage, holes in the chest, abdomen, or anywhere else in the torso. Unless you suspect that they're in cardiac arrest, which we learned in our previous chapter 8 about CPR. And then we're going to revert to CAB, which is circulation airway breathing. If we assume cardiac arrest, we're going to start with chest compressions and then address our airway and then our breathing. So when we address our airway, that's simply opening the airway, and then we start ventilating for them. If the patient is alert and able to answer question, airway's probably patent. If they can cough, they're moving air. They may not be 100% effective, but they're at least moving air. If an unresponsive patient, you may have to open their airway, whether this be the head tilt chin lift or the modified jaw thrust. if we suspect traumatic injury. And then we're going to inspect the airway for foreign bodies. Remember, we don't stick our fingers inside an unresponsive person's mouth. It's a good way to lose a digit or two. We want to look for secretions as well. If the airway is full of emesis or other secretions, we'll need to put the patient into the recovery position or suction the airway. And then, of course, if you have a hard time keeping the airway open, we may have to insert an oral adjunct, such as NPA or an OPA. Remember to identify your life threats. Assessing our breathing, we're going to assess our rate and the quality. Is it too slow? Is it too fast? Is it too shallow? Is it too deep? Or is it an irregular pattern? If the patient is unconscious, use the look, listen, and feel approach. You can see in this picture here how she is feeling with the side of her head or her face to feel if there's any air. I would probably be a little bit closer to actually be able to feel air movement. She is looking, but she's also doing the head tilt chin lift, so she may be able to feel if the patient's moving or breathing, but she's also looking, as you can see, directly at the patient's chest, looking for chest rise. And then she can very easily look for foreign objects and remove them if we need to. You could do a finger swipe or sweep without sticking your finger in the mouth or using a pair of McGill forceps to actually reach in and remove that. If the object is in far enough where we're not 100% positive or certain that we can get it, we don't want to try to lodge it further down into the patient's airway. If they're not breathing, we're going to open their airway and perform rescue breaths. As a provider with an emergency services agency, you should have at minimum a pocket mask with a one-way valve. If even better, it should be a bag valve mask that you can start breathing for the patient. Assessing circulation. If the patient is unconscious, we're going to check for a carotid pulse. If the patient is conscious, we're going to assess the radial pulse. Part of this is very intimidating to just walk up to a conscious person and grab a hold of their neck. Also, an unconscious person's, if in the event that they have a decreased blood pressure or pulse rate, it's kind of wasting time to go for a radial pulse. We're just going to go straight to the carotid where it's going to be a stronger pulse to assess that circulation. We're going to check the patient for severe external bleeding and then assess their skin color and their temperature. Also capillary refill, so we're going to squeeze the capillary beds and see how quickly they refill with blood. If you squeeze a fingernail bed and then let go, squeeze it for 1 to 2 seconds, let go. If it refills briskly between 1 to 2 seconds, they have good circulation and they're getting good oxygenation throughout the body if they have a patent airway. Anything delayed could indicate decreased perfusion, or it does indicate decreased perfusion. So the colors of the skin when we're assessing a patient, pale is going to be like a white or a very light in color. This indicates decreased circulation to that part of the body. That's where our capillaries are not getting blood actually supplied to them, so they're kind of blanched out. Flushed is more red in color. This indicates excessive circulation in that part of the body. Blue, or cyanosis, that you'll hear commonly referred to, is indicating lack of oxygen and possible airway problems. And then yellow, also called jaundice, is indicating typically liver problems. And then of course you have normal pink coloration of the skin. Okay, it's important once we get on scene and we perform our primary and our secondary assessments. That's probably sometime during the secondary or just after or before the reassessment or third, to go ahead and update responding units. We want to make sure that we kind of know what's going on with the patient and have addressed those initial life threats. And once we've done that, we want to update incoming units and let them know what they're dealing with. Some of the things that we should include: the age and sex of the patient, their chief complaint, level of responsiveness, airway status, breathing, and circulation. Try to perform all 4 of these steps of the primary assessment quickly. and decisively. We don't want to fill it with a bunch of extra talk and extra information that's really not pertinent. That's information that it can wait till later. Don't allow a conscious patient or a conscious patient's comments to distract you. Purposes of obtaining a history is to gather a systematic account of the past medical conditions, illnesses, or injuries. We want to figure out what happened leading up to the point where we are now, determine our signs and symptoms of the current situation. A lot of times with our history taking, we'll ask patients will readily give information about something that had happened to them 20 or 30 years ago. That's not really relevant to why we are here now. It is relevant information, but it's not something that we need to be taking necessarily in our immediate history taking part of our assessment. Try to use clear and systematic assessment process. We want to use a questioning process that is very decisive and to the point. And we want to learn relative facts, including serious illness, injuries or surgeries, recent surgeries, any kind of prescription medicines, any over-the-counter medications that they may take, or even any homeopathic remedies as well. Are they allergic to any medications, food, or even seasonal allergies? Here's a sample of sample history. This provides that systematic approach to obtaining that history of the patient. I'll give you a second to look over that. This is also in your textbook. Okay, here's a sample for our that you can use for our secondary assessment. This is called DCAP BTLS. This is more looking at traumatic injuries, but DCAP BTLS, DCAP BTLS, deformities, contusions, sometimes confusions, that's usually on the provider's part, abrasions, punctures or penetrations, burns, tenderness, lacerations, and swelling. There's also, for signs of injury, you can use DOTS, DOTS, that's deformities, open injuries, tenderness, and swelling. And this is kind of, like I said, more for traumatic injuries, but it can be used in medical situations as well. When you're actually physically examining the patient, you're no longer interviewing the patient. You're kind of more doing the hands-on assessment. You also keep in mind, you want to communicate with your patient while you're doing this. You want to ask for permission. Is it okay if I touch your left leg? Is it okay if I feel your belly? Things like that. If they're unconscious, all bets are off. They can't say yes or no. You're going to assume that they want the help that you're providing. But if they are conscious, it goes a long way for patient rapport with your patient to ask for permission to do things and manipulate the patient's body. If you want to move their arm out of the way so that you can assess an axillary or something like that. It can go a long way as opposed to just reaching out and grabbing someone and causing an uncomfortable situation for them. Secondary assessment, this is the more detailed version. This is the entire body. You can do it whether they're conscious or unconscious. Assume that all unconscious patients, especially if you don't know how they got there, or injured patients have spinal injuries. So we're not going to just take our patient and roll them down the stairs because we don't know. We assume that they're not injured. I guarantee you by the time they get to the bottom of the stairs, they will be injured. We want to stabilize the head and spine to minimize movement during the patient examination. And then also, ultimately, when we do move the patient, we want to minimize the movement and protect that as best as possible. Examine a specific body area or area of the body. This is performed on patients who have sustained non-significant mechanisms of injury, so they have an isolated complaint, or they have, same thing with medical patients, they have an isolated complaint, my belly hurts, things like that. Based on our chief complaint, we may focus on a body system, so a medical complaint of my chest hurts, we may be kind of going down a chest pain algorithm on the cardiovascular system. And then, of course, focus your attention on the immediate problem, or this helps focus your attention on the immediate problem. Remember, in our rapid trauma or rapid primary assessment or trauma assessments, we want to address any of those immediate life threats. We don't want to see them and say, oh, that looks bad, and keep going. We want to stop our assessment, fix that problem, and then make sure it's fixed, and then move on. Things like, yes, minor lacerations and abrasions, we can take note of that and then circle back around and take care of those. So for adult patients, their respiration rate normally is 12 to 20 breaths per minute. We really need to count the patient's breath for 1 minute to assess their quality of breathing as well. Sometimes you can look at a patient for 5 seconds and say, that's not good. Of course, you'll remember from American Heart Association, we want to check for breathing status no longer than 10 seconds. So if they're not breathing for more than 10 seconds, we want to go ahead and address that. That's a life threat. But taking that 1 full minute if in a breathing patient to assess the rate and quality, does it increase in rate? Does it decrease in rate? Looking at a patient's respiratory rate for 15 seconds or 20 seconds and then multiplying doesn't really do you a whole lot of good. And it can actually be quite inaccurate. The pulse indicates the speed and the force of the heartbeat, gives you a good indicator of whether or not they're trying to compensate for something. Circulatory. So on a conscious patient, we're always going to go first to the radial pulse and assess the heart rate and quantity there, or quality. And then, of course, for our unconscious patients, we're going to go for our carotid pulse. We can practice that on each other, your fellow students, in the classroom or the lab setting as well, so that you can become very familiar with that. We don't initially come across a lot of unconscious patients that we can practice taking pulses from in the classroom. When examining an infant, we're going to use our brachial pulse, or their brachial pulse, not your own, to assess for their heart rate. Our normal resting pulse rate or heart rate for an adult is 60 to 100 beats per minute. A lot of athletic adults can be 40 to 60 resting beats per minute. And then we determine the rhythm and quality as well. So if you come across somebody that has a heart rate of 50 before you start getting all antsy, go ahead and assess and kind of get a general impression of them. Are they a marathon runner or something like that? Or you can simply ask them what their normal heart rate is. Going back to capillary refill, this kind of helps, or this does help us assess the circulatory return of blood flow to the capillary vessels. We squeeze the nail beds firmly. You can also do the earlobe between your thumb and your forefinger until you've blanched the area out or it looks pale. Release it. Ideally, we want 1 to 2 seconds before they return to the normal color. Blood pressure. The systolic blood pressure is the force exerted on the walls of the arteries as the heart contracts. So this is what the blood that the heart is pushing through the system or into the system. The diastolic pressure is the arterial pressure during the relaxation of the heart. So this is kind of the back pressure. Hypertension exists when the blood pressure remains greater than 130 over 90 consistently. We want to check our blood pressure by palpation and feeling or auscultation. So auscultation is a normal, what we consider a normal blood pressure taking. So we're going to actually put the blood pressure cuff on the arm, use our stethoscope, and we're going to listen to hear the top and the bottom number of the blood pressure. If we can't, we can always revert to a palpated, where we put the blood pressure cuff on the arm and then we feel the radial pulse. We pump the blood pressure cuff up until we lose that radial pulse, let it out, and as soon as we have a return of the radial pulse, when we're releasing the air. That's our systolic pressure. We don't get a diastolic blood pressure on palpated cuffs when we palpate them. Our normal body temperature is 98.6 degrees Fahrenheit. Remember to check your skin color, temperature, and for moisture on all patients. Normal skin conditions are described as warm, pink, and dry. So you can use that in your pre-hospital report or when you're reporting to incoming EMS units. And then our level of responsiveness. We want to also keep an eye out for any changes in our patient's condition. Are they getting better? Are they getting worse? Sometimes after a syncopal episode or when somebody faints, they will start to get better. Sometimes they get worse. And then always remember to use the AVPU scale. Pupil size and reactivity. Examine each eye to detect signs of head injury, stroke, or even drug overdose. We should look at the pupils and determine if they are of equal size, whether they both are reactive to light. Do they retract briskly? The light we want to use is more of a pin light. We don't want to use a super bright light. Pupils of unindicated or unequal size can indicate stroke or a traumatic brain injury. They may remain constricted if a patient is taking narcotics. And pupils also dilate as a relaxed or unconscious state, or indicate a relaxed or unconscious state. Also, going back on pupils, if you see one pupil that doesn't move and it's not adding up with your patient's signs and symptoms, ask them if they have a fake eye. I've come across several times where there's a glass eye and those do not react to light. And the pupils are often unequal sides. You'll find a lot of times as a first responder, especially in rural areas, such as where we are, you may arrive on scene and be sitting with that patient for an extended period of time. It could be 20, 30, 40 minutes or more, depending on where you are. So you need to be prepared to continuously reassess those patients. So now we're going in beyond our third assessment or our reassessment. We're going into 4 and 5 assessments, and we may need to change how we're treating our patient to manage them for a prolonged period. So we want to recheck our level of responsiveness, our ABCs, continue to maintain an open airway, and monitor our breathing and our rate and quality. Reassess our vital signs and observe the patient's skin color, their blood pressure, reassess their chief complaint. Are they developing a new complaint? Has it got abated? And then, of course, reassess our effectiveness of the treatment that we've rendered. Reassess our patients who are what we would consider in a stable condition every 15 minutes. If they are unstable, we need to be reassessing them every 5 minutes. And that really all kind of goes by rather quickly, especially in an unstable situation. Reassessing vitals can actually be forgotten, especially in a high acuity patient. You've got a lot of things going on. You're trying to manage a lot of different things, and the actual reassessment kind of goes by the wayside. So we really need to kind of try to remember or prompt each other, our partners, to reassess the patient and see if those interventions are actually working. So our handoff report to our incoming EMS providers, our transport unit, this may actually be a fire department that has advanced EMTs or paramedics on staff, so they're a higher level of care than EMR. So we'll need to give a handoff report to them, even if they don't have an ambulance, and then they will give a handoff report to the EMS crew that comes to transport. But things that we should include is the age and sex, the history of the incident immediately involving why we are all here now today, the chief complaint, the level of responsiveness, how did you find the patient, have you moved the patient, how and why did you move the patient, their status of their vital signs, results of secondary patient assessment, were your interventions adequate, did they help, did they not help, any pertinent medical conditions, use that sample format. There's a lot of pre-printed notepads that actually have that on them that you can keep in your jump bag or your pocket or in your vehicle to go ahead and take these notes down very quickly. You can also just use a scrap of paper or a piece of cloth tape that you can write all this down so you don't forget it. Any interventions provided and how the patient responded to those interventions. So patients can generally be classified into two main categories: those who have had sudden illness or those who have sustained trauma. You could kind of add on a third for chronic illness, things that have been going on for a long time. They've maybe been neglected and it's kind of been compiling or compounding. And now all of a sudden they've tipped the scales and they've gotten to the point where they need the hospital. Patient assessment sequence can be used to determine examine patients who have experienced illness, trauma, or both. So remember, when you're examining your medical patients, you want to use that systematic approach on every patient so that you don't forget specific portions of your assessment. When we're caring for trauma patients, we want to perform our secondary assessment before taking our medical history. So that's really important, especially in trauma. We want to make sure that we're managing all of those life threats and before we start worrying about medical history, allergies, things like that. And then always avoid jumping to conclusions. Use the information that is given to you by the patient or bystanders and the things that you see there, and don't make any real judgmental calls on your assessments. Okay, to summarize Chapter 9, remember a complete patient assessment consists of 5 steps. We want to begin with performing a scene size-up, which should take into consideration our scene safety. Perform a primary assessment, which we're looking for anything that's going to, any immediate life threats, and address those. Obtain a medical history of the patient, and then perform a secondary assessment. And of course, remember, in traumatic injuries or trauma patients, we're going to reverse that. We're going to perform our secondary assessment first, and then try to obtain our sample history or our other medical history. And then after that, we're going to perform our reassessment, and then reassess as many times as we need to. And then remember, our scene size-up is a general overview of the incident and its surroundings. During our primary assessment, we determine and correct any immediate life threats. Steps for the primary assessment: remember, we want to perform a general impression, assess our responsiveness, perform a rapid scan, check and correct any immediate life threats for the airway, breathing, and circulation, and then finally update in responding units. Medical history provides a systematic account of the patient's past medical conditions and illness and injuries to determine the signs and symptoms of the current condition. We don't necessarily want the knee surgery that they had 15 years ago. Secondary assessment of the patient consists of our second assessment of the entire body from head to toe. We're looking at it in more detail. We're reassessing the injuries to our non-life-threatening conditions. If the patient is stable, reassess them every 15 minutes. Don't forget that they're there. Just a continued conversation can actually act as a continued assessment. But we do want to reassess those vitals every 15 minutes. And then if the patient is unstable, try to perform your reassessment of vitals or repeat those every 5 minutes and look for any changes in those vitals. And then we want to perform or provide a concise and accurate handoff report to EMS personnel. Note-taking goes a long way in helping you provide that accurate report. I've run into situations where I'll ask a question, I'll get an answer, and I'll immediately forget what I was told because there's so many things going on all at once. So we have 3 review questions for Chapter 9. To help you review this information, of course, we will review in the classroom or the lab sessions of this class. So if you have any questions that you come up with while you're reviewing the material, please write those down, bring those to the classroom, And in the beginning of class, when we have our review session, we'll go over those questions. But here are the 3 questions. Number 1, which of the following steps might be performed during the scene size up? So make your selection. So the answer is C, notify dispatch to send fire personnel. So this is going to be when we arrive on scene and our windshield survey and we realize we actually need more people. This is beyond what we can manage, whether it be lift assist, traffic control, there's a fire that the fire department needs to put out because they like to do that kind of thing. Whatever situation you see that you need more additional resources. Number 2, the goal of a primary assessment is to, please make a selection from the following choices. Okay, the correct answer is D, identify and treat any immediate life threats. Remember to kind of keep in the back of your head what's going to kill them in 60 seconds or less. I need to identify that and treat it and mitigate it. Number 3, after performing a primary assessment and treating any immediate life threats, you should next which of the following options? The correct answer is A, determine priority of a patient care and transport. How quickly do they need to get off scene and to the hospital?